This week on the Back Table Podcast.
The biggest takeaways for me for this surgery are really you have to find your thyroid notch and you have to be absolutely sure. And then you also have to remember that the hyoid bone is the only bone that you can get your finger under. And so if you can't get your finger under it, then you're probably not at the hyoid. And so you might want to take a step back and reevaluate where you are. Because I think that part of the operation is where you can really hurt someone if you're in the wrong spot.
Hello, everyone, and welcome to the Back Table ENT Podcast, where we discuss all things ENT. We bring you the best and brightest in our field with the hope that you can take something from our show to your practice. Now, a quick word from our sponsor. For over a quarter of a century, Medtronic ENT has been at the vanguard cultivating hands-on advancement for ENT professionals. From the precision of PTI aiding in parathyroid detection to the cutting-edge drug delivery of Propel implants and the accuracy of their navigation systems, Medtronic integrates high-level technologies into one seamless surgical experience. Dive into the latest ENT innovations with their live events, webinars, and the visiting clinician programs. Engage in live surgeries, faculty-led discussions, and exchange best practices in their state-of-the-art training labs. Their mobile labs and unlimited Medtronic Academy e-learning content, including procedural animation, deliver the future of ENT care directly to your fingertips. Visit medtronicent.com. Now, back to the show. My name is Gopi Shah. I'm a pediatric ENT, and I'm so happy because I'm sitting across from my favorite, lovely, brilliant co-host and partner in crime, Dr. Ashley Agan. How are you today, Ash?
Hey, good morning, Gopi. I'm doing great. And I'm so excited because today we have my old co-resident, Dr. Chris Liu. So all three of us were in training together at some point because Chris and I were in the same class and Gopi was our fellow. So it's exciting to have us all kind of back together.
Yeah, and we were partners for a long time too.
That's true.
And the same department at the same institution. So it was nice to have each other for several years.
So Dr. Christopher Liu is a pediatric otolaryngologist, and he's an associate professor of otolaryngology at the University of Texas Southwestern Medical Center, practicing at Children's Health in Dallas. He's also the fellowship director of pediatric otolaryngology there. And he's here today to talk to us about thyroglossal duct cysts in children. Welcome to the show, Chris. How are you?
Doing great. Thanks for having me on.
So we like to start off the show with giving you a chance to just talk more about your background and your current practice for people who may not know you.
So, yeah, I did my training at UT Southwestern with Ashley. We were co-residents together. So it was a fun 5 years. And Gopi was our fellow for a year and then our faculty for about 2 before we graduated. And then I did my fellowship at the Children's Hospital of Pennsylvania at CHOP and came back to Dallas and have been on staff at Children's Health Dallas since then. And I've been basically the point person for the head and neck program or the lead surgeon for the head and neck program at Children's Health for the last 7 years. And that role has given me the opportunity to basically see a lot of thyroglossal duct cysts. And so, we get a lot of referrals. For some reason, Dallas seems to have a lot of kids that have thyroglossal duct cyst problems. And so we're constantly seeing these patients in our practice. And I've learned a lot during the last 7 years that I don't think I really learned during residency. So I'm really happy to talk about that today.
Cool. Let's get into it. How do patients with a thyroglossal duct cyst usually present to you? Is it the textbook, kind of a midline neck mass? What are you seeing?
So I think most of the kids that we see, well, actually, I think it's more of a 50-50 breakdown, but half of the kids that we see, parents bring them in because they notice a bump on the neck. It's never bothered the child and never been infected, and it's just kind of been there. And a lot of times parents will assume that it's like an Adam's apple of some sort because it's just right in that spot. And they don't really think much of it until they mention it to the pediatrician, and the pediatrician sends them to us. So that's half of the patients that we see, and the other half are patients who don't know they have a cyst until they have their first infection. And so those patients will come in with an abscess or sudden increase in size, redness, pain, fever, swelling. That's the second type of thyroglossal duct cyst patient that we see. But yeah, usually that's how they present. It's usually in those two kinds of scenarios that we see them.
Yeah, I feel like you're right. It's either the consult in the ED or the hospital, right? As you said, because they're actively infected or they're coming to you. And sometimes they start pretty young. Have you noticed that, Chris? Like sometimes they might get referred early. What do you find is the age range in your practice?
I think most of the kids that I see are between 2 and 6 years old. That's probably the average. Occasionally I've seen kids less than a year, and those kids are a bit difficult, I would say, trying to decide when the good time it is to do the surgery. It's kind of odd. Very rarely will I see like teenagers. Teenagers are not very common at all. I'd say that maybe like only 10% of that practice is teenagers. We don't see very many of them.
And in your practice, have you noticed any common risk factors or anything? To me, it's random unless, I don't know, have you noticed any risk factors or patterns for the kids who have them and the kids who don't?
So, no, I have not seen a pattern. It does feel very random. I've had 1 or 2 families who've had multiple siblings with it, so maybe there's something going on there, but that's maybe like 1 or 2 out of like 100 kids that I see. But as far as I can tell, the pattern is fairly random. There's no family history usually, and the parents don't ever recall anyone that they know that's had the same problem.
Yeah. I mean, it is the most common congenital neck mass, right? That's pretty common.
Yeah, it is. And I think there have been cadaver studies in the past showing that there's probably a lot more people out there that also have thyroglossal duct cysts, small ones that are never symptomatic. And so we don't ever know about them. Those are the patients that we never see, since we're only seeing the ones that are visible and or infected.
Yeah, I feel like on the adult side, like I'll get patients who have incidentally found very small cysts that have never caused any problems, but they were getting an ultrasound for something else. And I saw one paper like in the radiology literature that said just a little under 1% of adults can have incidentally found thyroglossal duct cysts. So I think you're right. I think there's probably more people walking around out there with them than we even know.
Yeah, I've definitely seen a few kids in my practice where they're getting like an MRI of the brain or the neck for another reason. Oftentimes it's for like, sleep apnea or autism or something like that. They're getting an MRI head, and radiology will mention that there's possibly a thyroglossal duct cyst right next to the hyoid or in the foramen cecum. And those patients can be a little awkward because you're kind of like, well, that's the textbook answer is excision, but you probably would have never known you'd had this unless you had gotten the MRI. So it's really up to you what you want to do.
Yeah. And we'll get into that decision-making momentarily. But before we get there, as we walk through the patient visit and before moving on to the physical exam, is there anything else in your history taking that's important to know? I mean, you want to ask about, has it ever been infected? Has it ever been drained or IND'd? Anything else that you're asking about?
I feel like with thyroglossal ducts, a lot of it is going to be based on your physical exam, right? Like your diagnosis, a lot of it is going to be based on your physical exam. I think one of the most important details to me, honestly, is the history of infection, because things that can show up in that area or in that vicinity, not necessarily midline, but sort of in that submental, submandibular area, potentially like kind of maybe a little lower than that, those tend not to get infected. So dermoid cysts don't usually have a history of infection. Ranulas don't usually have a history of infection. And same thing with lymphatic malformations too. Like you can have exacerbations, but those are not very frequent. And there's just kind of a look to how these thyroglossals get infected. And so if a parent comes in and tells me that this bump in their child's neck has been infected in the past, has been drained, needed antibiotics, fluctuates in size, gets red, then the first thing I do think of is thyroglossal duct cyst. That shoots to the top of my differential. And so that's like the one key part of the history that kind of clues me in to whether I think this is a thyroglossal duct cyst or not.
In terms of your physical exam, so we think of the, midline neck mass, we might have them stick their tongue out and see if it moves, kind of that pathognomonic finding for that. When a child doesn't have a history of an infection and you have a midline neck mass, do you have a way to kind of help yourself lean more towards thyroglossal versus dermoid versus like a lymph node? Because without that history, sometimes for me, the dermoid versus the thyroglossal in the midline can be a little tricky.
So, yeah, I'm sure we're going to talk about surgical technique later on, but I think dermoids tend to be really, really smack dab in the center, and there is usually no history of infection. But oftentimes what I tell families is that I think this is a dermoid. We're going to do the surgery like a dermoid, but if it starts to look like a thyroglossal duct cyst, because the contents of the two entities are different, then we are going to convert to a cyst trunk because that's going to be the appropriate surgery. So a lot of times what I'll do, if I'm not like 100% sure, at least intraoperatively, and this is a little different than how I normally do my cyst trunks, but if I think that there's a dermoid, I will actually expose the capsule of the cyst. And if it looks like a dermoid, I'll take it out and then incise the cyst off the table to prove that the contents are dermoid before saying, okay, your child only needs a simple excision. Because oftentimes it's really hard to tell. They look the same on ultrasound, they look the same on imaging, and they kind of look the same on, physical exams. So it's like really tough sometimes.
Yeah, when they come to your clinic, that midline, if there's no infection history, I agree, it can be really tricky.
Basically just prepare the family for the bigger operation and be pleasantly surprised when you do the simple one. And most times, I don't think I've ever had a family upset about me doing the simpler one.
For sure.
So.
Anything else for your exam other than just being able to palpate the neck and feel the mass?
Yeah, I mean, outside of just the location, I think there's a couple of things that, and this is more relevant to the patients that have had infections in the past. Outside of a bump, you can also have like basically an ugly looking scar there or a hypertrophic looking scar. Probably, I think those tend to form with thyroglossals because after the infection is gone, you can still get some chronic inflammation from that sort of mucoid drainage that tends to want to leak out through that area. You can have a fistula, you can have an ulcer. And these are sort of later findings after an infection has been drained, or let's say a cyst has spontaneously ruptured. But oftentimes when I see that, a lot of times parents are really worried about it because of the appearance. But, I tell them, look, now that it's draining, it's probably not going to get infected again. It might be kind of a hygiene issue until we have our surgery, but at least there is something there for me to follow, right? So the worst case scenario is that it completely heals and disappears, and then I can't really help you until it shows up again. But as long as it's draining and there's an ulcer or something there for me to follow, then we're good to go.
Is there ever a reason to scope these kids? Like, the rare thyroglossal that has maybe some more swelling posterior to the hyoid, or do you ever have symptoms? I mean, I've never had a child that had trouble swallowing with this, but I would imagine in a higher volume practice, you might see something like that. I don't know.
So personally, I have not routinely scoped patients for this problem, even when they're infected. I have only had one patient that had a foramen cecum component that was significant enough that was causing airway symptoms. But in the absence of airway symptoms or dysphagia or anything of that matter, I don't routinely scope these patients.
Yeah, they're little too. A lot of them are little kids, so it's probably not worth the struggle, the drama.
It's not.
Right. And going back to the sort of classic description of thyroglossal and the exam findings where you have them swallow and the thing moves, I can't tell.
It doesn't change.
And there's three. That's like really hard to tell.
Yeah.
For the kids that present to you with an infected thyroglossal duct cyst, so like the child in the ER or the child that's been admitted, usually we do the IV antibiotics and see. But my question for you is, what do you usually like from Perix? And when it's not getting better, the peds ENT, we love the 48 hours. Let's say nothing's really changed, but there's warmth and fluctuates. How do you usually manage that?
Honestly, I think there's a lot of controversy. It's a bit of a gray area in terms of just kind of generally how to deal with an infected congenital cyst, right? Like I think as residents, we're taught don't drain the cyst because once you violate the capsule, it makes the subsequent surgery harder. And when I first started my practice, that's sort of the attitude I took. But over the last couple of years, I have found myself being much more aggressive about draining these infections and not letting them fester for too long. Because, at the end of the day, you can't operate on a kid that has an infection. So the goal is, and this is why I tell families when they come in, I'm okay doing a day or two of antibiotics because obviously no parent really wants their child to have surgery, go under anesthesia too many times. And I tell them, look, we can do antibiotics for a few days, but if they're not getting better, we don't need to keep doing the same thing, right? Like, let's just go ahead and get it drained, get them over the hump, treat the infection, so then we can move on to the next step, which is drainage. Part of the reason I have changed that practice is because when you think about how thyroglossal ducts look, there's actually a lot of data that supports the idea that these cysts are not solitary cysts. And what people see is like the large cyst, the one that got infected or the one that's most visible. But oftentimes behind that cyst, there's a network of ducts and network of small cysts or thyroglossal elements that can also cause problems in the future. And so for me, when we do the surgery, it doesn't really matter to me whether the cyst wall is intact because I'll do the surgery at the same time. And so with thyroglossal, at least, I have a very low threshold to drain these just to get these kids over the hump so that we can move on to the next step. In terms of antibiotics, I know a lot of people like to use clindamycin And there's no like, I haven't done a study on this, so I'm not going to say that like I'm the world's expert on this. But what I have noticed is that a lot of times the infections, sort of the bacteria that are identified in these thyroglossalal duct infections tend to mirror the bacteria that you find in upper respiratory infections. So there have been a lot of cases, and this is purely anecdotal, but there have been a lot of cases where we have kids get put on Clinda because they assume, or the pediatrician assumes it's a skin and soft tissue infection and doesn't get better, and the child actually comes back positive for H flu. And so nowadays, I usually will start patients on Augmentin, and if not Augmentin, I'll do Omnicef instead of clindamycin, just for that gram-negative coverage.
So in terms of the antibiotics for IV, your first line usually is Unison then, if they're admitted for IV?
Yeah, something that at least covers H flu, or something that is more directed towards like, what you would normally give for sinusitis or OME.
Yeah. I find that, I used to wait for the IV antibiotics, but it didn't really make a difference because after about 48 hours, if it's not better, it didn't get better after the 72 or longer. So I agree. I've been a little bit more just like, okay. But when you do take them for the IND, how aggressive are you in terms of opening things up? How aggressive are you when you wash out? And do you leave anything in, like a Penrose or a drain?
So can I be honest with you? I have not done an IND on a thyroglossalal in a long time. And I think part of it actually is because I tend to drain them in clinic with a needle.
Ah, okay.
So it's kind of funny, like nowadays with the thyroglossalals, unless they're like really young or just look really infected, or where it's just huge, like the entire neck is swollen. I feel like a lot of these kids nowadays, we kind of manage as an outpatient. If it's just kind of isolated swelling or redness over the area, they'll go to the ER. ER will see them, give them antibiotics, tell them to follow up with the ENT in a few days. And then usually they end up in my practice. And so if they're doing better, obviously I say, okay, keep doing the antibiotics. But if they're not, I give the parents a choice. Like, look, we can plan to do it the next day as an add-on. Like you can go home, but then we'll, bring you in and get it done. Or I can tap it with a needle in the clinic, drain it, and it may recollect, but there's a good chance it won't. And you spare yourself a trip to the OR. And I would say most parents want it tapped. They're like so ready for this thing to go away. They're just like, do it there, do it now. If it's a young kid, we'll papoose them and drain it. If it's an older kid, usually the older kids are perfectly fine. They don't usually have any trouble with it. So it's not that common, at least as far as I'm aware. We haven't had to drain any of these frequently. Let's put it that way. I actually recently, I don't want to say never, because I recently just did a kid that somebody else had drained, but the kid was a year old and they got like 30 cc's out of the neck. So that kid needed an OR drainage. But if it's like an isolated area, I don't think it's absolutely necessary to do like an IND with packing.
When you're doing this needle drainage in clinic, do you just clean the skin with an alcohol wipe and then poke it with like an 18 gauge?
Do you numb it up at all with like EMLA or anything like that?
So yeah, I do use EMLA, and then I tell the parents it's usually just one stick. And most of these kids, where if they're already on the verge of getting an abscess drained, that thing is
ready to pop.
You're not going to miss, right? Like it's right there. So I tell them it's usually just one stick. We get it out. They're going to fuss. They're going to cry. But you know what? At least you get to go home today, and he's going to feel a lot better by tonight. And I've actually not had any parents, at least in the last year, decline that offer, which is good, I guess.
Do you send off your pus for any reason?
Yes, I do send it for aerobic and anaerobic. And going back to sort of how my practice has slowly changed over the last couple of years in terms of what antibiotic to recommend, I had a run of kids come back with Haemophilus. And so we've had to change their antibiotic from clindamycin to something else.
And Gopi, you're probably seeing patients in the ER inpatient setting. So how aggressive are you when you drain them? What do you do?
Well, that's why I ask, because I'm always like, I don't want to be, it's different than a neck abscess, right? Just because I'm like, I know this is eventually going to need to come out. And if I am going crazy at, opening every single, then I feel like I'm going to make it worse, make the recurrence rate or something at the time of excision worse. So a lot of the kids that come into the ER, it's not a common admission, but when they come in, they usually do get admitted depending on, how big, how red. By the time they get to the ER, it's usually something fluctuant that requires at least IV antibiotics. And so I'll make a little incision and I'll just take a small mosquito, just kind of gently open it up, irrigate real gently. And then I might leave like a tiny Penrose in, might cut it lengthwise so it's not this big tube. I feel like the rubber band ones are a little too skinny and they tend to fall out. And I might leave it in for 24 hours and then take it out and let them go, something like that.
Yeah, I think that's a good approach as well. I mean, at least you don't have to worry about recollection as much. The one thing I do warn families, though, with these INDs is that there is a risk of fistulization once you've kind of created an opening. And it's not something that I see as a complication or I tell them that it's a complication. It's one of those, if it happens, don't be surprised. Because, when parents see something like that, you're definitely going to get a phone call or several about it. And so the other thing I've realized with these patients is the management for these thyroglossal duct cysts and their infections and whatnot, it's fairly predictable in a way. And so a lot of times, as a parent, it's probably very scary. Your child has a neck mass, it's infected, you don't know what's going on. But if a physician kind of explains to you sort of things that could happen with what we do, like with an IND, there's a risk of fistulization, ulceration, but that's okay. I find that these families are actually, like they kind of get on board with the program and work with you, knowing that the ultimate goal is to get this child to a point where we can excise it.
Yeah. For your workup, let's say, you had a kid that you had to do like a little needle aspiration, cool things off in clinic. How soon do you see them back to talk about surgery? Or do you talk about it at that time and go ahead and schedule it because you're scheduled out for months anyway?
Yeah, I mean, I think it depends on the family, and I think you could do it however ordered you want. Ultimately, the kid needs surgery. So if the parents are like, yeah, we're ready, just go ahead and just get the kid on the schedule. I'm like, yeah, sure, that's fine, let's do it. But I do want to see them back within a week or so, just to make sure it doesn't recollect and make sure that they're making progress. Sort of my rule of thumb in terms of time of infection and time of surgery, I would say maybe 6 to 8 weeks is reasonable. Have I had to do kids who are actively infected because they were infected on the day of surgery? Yes, but I would prefer not to. It's doable. It's just kind of a little harder to do.
Yeah, for sure. When you're working up the patients, do you like ultrasound? Do you ever do a bigger, study like a CT or MRI?
Really good question. So I always get an ultrasound just to double check. I think classically we're taught to always get an ultrasound on the neck, and the rationale is that you could have some thyroid gland abnormality or an absent thyroid gland in the presence of a thyroglossal duct cyst. To be quite honest with you, of the last 7 years, we've only maybe picked up 1 or 2 thyroid abnormalities that were unexpected. We have had a few kids who've shown up with a midline neck mass that did have an absent thyroid gland, and whatever mass was actually in that midline actually looked like thyroid tissue. So that does happen too. I think it's helpful to get the ultrasound, at least just to confirm that it is cystic, because in the off chance that is not, then you definitely have to kind of work that up a little further before you recommend surgery. One of the challenges that we have run into, though, with ordering ultrasounds is that at least, and this may actually be institutional or sort of how the radiology techs do their job, but if you order just an ultrasound neck mass or neck, sometimes they actually don't scan all the way down to the thyroid gland itself. And so then you're kind of in this awkward, like, do I reorder the ultrasound? I mean, the ultrasound that says that there is cyst, but do I go back and have them redo it to get the gland? And so that, I think, is sort of the bigger question of whether that's actually necessary, at least in my mind, because it's very rare that we actually do see a thyroid abnormality that's unexpected. In terms of tertiary level imaging, I don't routinely order CT or MRI. I don't love CT scans in young kids. I know there's a lot of data showing that the CT scans we use now don't use that much radiation, but any chance that I can to avoid doing it, ordering a CT, I try to. On occasion, I will order an MRI for really special circumstances. So some of it's just based on past experience and getting burned, right? So I've had, in really young kids, like literally infants. So we don't see a lot of thyroglossal ducts that are problematic in really young kids, like 6-month-olds or 8-month-olds. And so in the off chance that I have one of those kids, I will request an MRI just to kind of see, just make sure that I'm not missing something. And then on the kids who've had previous surgery, I will also order an MRI just to kind of see what I missed or see what was done previously if it was not, if I was not the original surgeon. So those are really 2 primary cases where I would get imaging. And partly it's just to help me with surgical planning and to figure out like where I need to go to make sure I get all of this out.
When do you consider waiting to do surgery? Do you have certain ages, and you mentioned, if they're older and it's incidental and a different imaging, tell me about the thought process of when you wouldn't necessarily operate.
The way I phrase this to families is that a thyroglossal duct cyst is not life-threatening, right? And if it's not really bothering the kid, then you don't necessarily have to have it removed now. And it's okay to wait until the family is ready or until the child has a problem for the first time. I get that question a lot for the younger kids. So like the 1 and 2 year olds, a lot of parents feel like surgery is just too much at that age, which is completely fair. And so those patients, I'll tell them, look, if it's not bothering your child, you can wait as long as you want. I'll be here. Just give me a call and we'll get it taken care of whenever you guys are ready. Now, the caveats are symptomatic patients, right? So patients who have a large cyst, even though it's not bothering them, if it's visible, in my mind, that's symptomatic, right? It's visible. It's cosmetically unappealing. It's perfectly okay for parents to leave it, but a lot of those parents will want it removed, and that's okay. And I'm like, yeah, that's fine. And age to me doesn't really matter. If they want it removed at a year, that's fine. But it has to be sort of a shared decision with the family. Like, I'm not going to tell them this needs to happen. I just tell them, look, the solution is surgery. The timing is yours. Like, you get to choose. It's a little different when you're talking about a kid that's getting a lot of infections, though, right? So that's a different kind of beast. And a lot of these parents do want surgery because by the time the child gets their second or third course of, hard-hitting oral antibiotics, parents are kind of ready for it to be over with. And those patients, I recommend excision, not as soon as possible. That makes it sound like it's like immediate, but like just don't wait a couple of years. Like, let's get it done in the next couple of months so that we can break this cycle.
So Chris, tell us about your surgical approach.
Do you want the history of it or just like what I do now?
Yeah, the history. I want to know the evolution.
The evolution. Oh my God. So every institution, I think, does their thyroglossal cyst trunks a little differently. And kind of how I was taught in residency and actually in fellowship, you find the cyst, you dissect the cyst out, you follow up, you find the hyoid. And maybe this is just me like being a resident, not fully understanding what's being done. But my impression at the time when I was learning the operation was once you found the hyoid, you kind of go above it and then you kind of start boving muscle down. And like most of the time, the senior resident's like, yeah, man, that's like the base of tongue. So like get that down. And then you find your hyoid and we use these really janky looking like Mayo scissors, the curved Mayos to cut the hyoid bone. But half the time, those Mayo scissors are dull. So then you're just like struggling and it's like a big struggle. But you take everything down, you release the hyoid, and then allegedly there's a tract that you tie off, which was a little unclear to me at the time. And then you're done, right? Like you do that and that's like the cyst trunk. I mean, that's kind of how I was taught, or at least how I learned it. I don't know if that was actually what the intention of my attendings were in terms of how I was supposed to learn it, but that was what I understood needed to be done. And that's what I started off doing when I first started practice. I was in the suprahyoid area. I kind of did what we normally did. But then when we got behind the hyoid bone where, quote unquote, the foramen cecum is supposed to be, oftentimes people talk about, I think there's like a general fear of creating like a pharyngotomy. And so people have a tendency to just say, okay, the tract is probably here. So like take a little bit of it, but just tie it off, right? And so that's kind of how it was taught originally, or at least how I learned it. But over the years, there was a period of time where I had a lot of recurrences afterwards. And I started doing some research. And I came across this paper by Jeff Kompel at USC. I've never met him, but Jeff Kompel, I'm going to give you a shout out because you're like my hero. And one of these days I'm going to find you and introduce myself because that's how I do my surgeries now. So it's called the Kompel method. Oh, and the other thing was, Dr. Mitchell, he's told us before in the past, he's like, sometimes with these recurrences, you just kind of have to do almost like a central neck dissection, right? Like you kind of ignore the location of the cyst and you have to kind of just take the stuff around it. And so basically the Kompel method, I think the biggest contribution of that paper was really on how you deal with the suprahyoid and foramen cecum area. Because like everyone does it a little differently. Some of it, people tend to limit how much they take because they worry that they might do a pharyngotomy. And, when you get into that foramen cecum area, the muscles aren't super organized. The intrinsic base of tongue muscles are not very organized in the same way that skeletal muscle, like the suprahyoid muscles, are very organized in their sort of vertical orientation. So you're just kind of figuring it out. You're kind of making it up as you go. And actually, I do tell families that although there are certain steps to the surgery, we do kind of like in certain areas kind of have to make it up as we go because you just don't know what you're going to encounter in that area.
Yeah, the anatomy isn't quite as, beautiful and precise.
Yeah, there's not like fascial planes that you like dissect out in the base of tongue. So when I do the surgery, if it's a cyst that's never been infected, you just make an incision over the cyst and, you go down And then if it's an infected cyst or one that has ulceration or skin involvement, I make that fusiform incision around it to make sure I kind of get around it superficially before I kind of dive down deeper. The one thing that I don't do is if I know it's a thyroglossal duct cyst, I don't look for the cyst. So I take a small rim, like maybe a few millimeters of soft tissue around the cyst, and I basically just dive down after lifting kind of a short inferior subplatysmal flap. I'll basically dive down onto the strap muscles pretty much almost immediately. And I try to stay maybe 2 to 3 millimeters, a couple of millimeters inferior to sort of the area of concern. And I find the midline raphe, and I go straight down the midline raphe until I see airway. And once I see airway, I expose it a little more. We unzip it vertically a little bit just to kind of make sure that that's the airway. And then I take the medial, I would say about 5 millimeter of strap on each side. And to me, people do ask, I've had residents ask, well, why aren't you preserving the strap muscle, right? And I don't for two reasons. One is that you're going to be cutting the hyoid bone anyways. So you're disarticulating that strap muscle medially anyways, regardless of what you're going to do today, right? So why does it matter if you disarticulate it up next to the hyoid bone versus maybe a centimeter or two inferior to it? And two, I know that if I cut through the strap muscle there, I'm giving myself a little bit of space around the cyst to make sure I catch anything that I may have missed, right? Like potentially a small kind of cystic or a protrusion that I may have missed. So it just kind of gives me a bigger margin of safety in terms of making sure I get around the whole thing. Once I divide those strap muscles medially, the one move I think that is really helpful in identifying the hyoid bone is actually you put your finger onto the thyroid cartilage. You should be able to feel that notch when you slide up, but when you put your finger on the airway and you turn your finger up and you slide along the strap, deep to the strap muscle superiorly, you'll feel the hyoid bone, right? Because the strap muscles themselves are attached to the hyoid bone, so they'll lead you to the hyoid bone. And the hyoid bone is actually the only structure that you can slide your finger underneath. So that's kind of what I do to find the hyoid bone is I basically use the strap muscles to lead me to the hyoid bone, and then I find the thyroid cartilage just to make sure, you always want to make sure that the thyroid notch is there. And then the other thing that kind of clues me in is that I can lift that hyoid bone up with my finger, because you're not going to be able to do that within any of the other kind of structures like cricoid or thyroid. You're not going to be able to do that at all. And then this kind of goes back to Gopi. I know you mentioned, what's the difference between older kids and younger kids. And so when you kind of think about how the hyoid bone is oriented in older kids, so let's say in a male, right? So when you're younger, like you mentioned, your hyoid bone basically is telescoped on top of the thyroid cartilage. So that move where you slide along the airway with your finger up, you're always going to be deep to that hyoid bone. You're going to feel it. In older kids, this just dawned on me a couple of months ago. So in older kids, in men, you have an Adam's apple, and that Adam's apple is your thyroid notch. The reason that thyroid notch is so prominent is because your hyoid slides superiorly as you get older, and then it kind of falls back a little bit, right? So it becomes, I don't know what the phrase is, but it's not telescoped anymore. And so actually older kids are a little more challenging because their hyoid is going to be a little deeper, and it's going to be above the thyroid notch. So it's going to feel deeper when you're trying to look for it. And so rather than, where you kind of try to bovie on top of the muscle to get down to it, and a lot of times that muscle is really thick, I actually find that sliding technique from inferior is a very easy way for me to find the hyoid bone, even in older kids, when you don't have the benefit of a kind of a telescoped airway.
When it is a younger kid, and let's say that the hyoid is maybe very low, or maybe even if it's not quite telescoped, it makes sense that it's going to be a little bit more prominent, more interior. It's not as superior and deep as in an older kid. But just by the proximity, is it easier to get into the thyroid membrane if the hyoid and the thyroid cartilage are that close together, even if you can kind of pull it up, or not really, because you can pull it up and kind of stay on it?
Yeah, so I can pull it up. So basically, once I find the hyoid bone, I can feel the hyoid bone. I actually turn my attention superiorly, and then I finish raising the subplatysmal flap superiorly. I bovie through the fat, and then you bovie through the skeletal muscle, like the platysma, and then eventually you'll kind of run into the vertical muscle fibers of the suprahyoid straps. And then at that point, what I do, once we kind of get better exposure superiorly, we turn our attention back inferiorly again. So once you can feel that hyoid bone, I think it's a little hard for me to describe how I do it verbally, but basically where we cut the strap, like 5 millimeters laterally, that lateral kind of extent, the most lateral part of our cut, I basically have the resident or myself, we just follow that vertically up. And because the strap is going to lead you to the hyoid bone, what you're going to feel is you're going to cut through muscle and all of a sudden you're going to bump into something firm, and that's going to be your hyoid bone, right? And once I bump into my hyoid bone, and this is a little bit by feel, but basically I use the bovie to kind of bovie over the top of it, over the anterior part of the hyoid bone until I can reach the superior portion of the hyoid bone. And I'll create like a little tunnel or a little kind of pocket for me. And then I take like a Jake dissector or a mosquito, and I put the Jake dissector through that pocket superiorly, and then I dip behind the hyoid bone and I pull it up laterally, and I open the dissector. And then at that point, I tell the resident or the assistant, take your bovie. If it's a young kid, you'll be able to bovie through it. Take your bovie and just, kind of like how we normally do our dissection, like our soft tissue dissection, just bovie between my tines and you're going to get through.
Yeah, you're kind of like presenting the bone with the dissectors to your assistant.
Yeah, you're basically presenting the bone to the assistant. If the bovie doesn't work because the bone is too ossified, I actually don't use heavy mayos anymore. I actually use the orthopedic bone cutters. So you can get these like small bone cutters. I think they're used for like fingers or something. I don't know exactly what they're called, but we just refer to them as the ortho bone cutters. Sorry.
Good thing our audience is an ENT audience. Like they might be for some fingers.
So those bone nippers actually look like the same bone nippers that I use for my aquarium. So that's actually why I thought about using them. Because I know I've seen them in the ortho sets before, but they're amazing because they don't ever get dull.
Yeah. Why struggle, right?
Yeah. So, use a bone cutter to cut bone. So then I use that. And usually what I want, because the bone cutters are so much more precise too, rather than having the resident or the assistant take like one big bite through the hyoid bone with the bone cutters, I actually tell them to, take a little bite and then we'll bovie the marrow to control the bleeding, and then just take another little bite and bovie the marrow, because the bone cutter is just so sharp and precise, you can get away with that. So then that's how we cut through the hyoid bone. So once you make your cuts, then you do the superior part of the suprahyoid part. And this is actually where the Kompel method was really helpful, or how when he wrote his paper, he did a really good job of showing what he did. So basically you look superior to the hyoid bone, but in the midline raphe, right? There's a midline raphe in the suprahyoid straps, and you dissect down in the raphe until you see sort of this fascial layer. So it's kind of that fascial layer that transitions into the intrinsic base of tongue muscle, right? That's that fascial layer that people always see when they're like kind of boving away that skeletal muscle. And so once you see that fascial layer, that is the deep extent of that part of the dissection. And so anything superficial to that, all that skeletal muscle superficial to that, is like fair game. Once you make that identification, you can make like a very precise, controlled move to kind of present all that superficial or all that strap muscle that's superficial and just divide it all usually in one go. So it's literally just like a couple of moves to get that superior part down pretty quickly. And then once that is done, you've released all your skeletal muscle from the attached skeletal muscle to the hyoid bone. The hyoid bone's been cut. So the last part that's attached to the patient is right behind the hyoid bone, and that is actually that will lead you into the foramen cecum. So what I do now, because I actually have been burned before tying it off once, it was very traumatic. Basically what happened to me was early on in my career, I had a patient who did have a very obvious tract, and I tied it off. And what ended up happening was that tract became a cyst because now this mucus had nowhere to go. And he developed airway obstruction, actually, because it became a big base of tongue cyst that was obstructing his airway. So after that traumatic event, so now anytime I see a tract, I chase these to as far as they'll go, right? Basically what I'll do at that point is that final attachment to the hyoid bone, I'll take a bovie and start to kind of core out that area. And I'll do it very slowly to see if there are any cystic elements or if there's a tract in that area. And I'd say I haven't looked at my data recently, but I'd say at least a third of patients will have something there. If not like a millimeter cyst, I've seen full on 1 centimeter cyst back there. I've seen tracts leading all the way to the base of tongue. So I always core out that area to make sure that there's nothing there. If I don't see anything obvious, I might not go all the way to the back of the tongue. I usually won't. But if I do see something, I will follow it and I don't ever tie it off. And if it means that we are going to get into the pharynx, that's fine. So I do warn families that sometimes that will happen. And so once that is done, then the specimen is out. If you do create a pharyngotomy, usually it's a small hole. You just repair it primarily and do your leak test. And if there's no leak, you're pretty much good. How you manage that afterwards, I don't think there's like a set way to do it. Originally, I used to, keep these kids MPO for a few days and, kind of like how we do our cancer patients. But, at the end of the day, these kids are like healthy. They're not smokers. They're not drinkers. They heal really well. I've not really had any patients fistulized because of that.
How do you close your pharyngotomy?
I just simple closure, 304 of Vicryl, depending on the size of the kid. And then you can oversew the muscle too, right? Like, so the muscle, the intrinsic base of tongue muscle, you can kind of sew that together too to kind of give it some belt and suspenders. And then we do a leak test afterwards. If I'm not super confident in the repair, I'll put a round drain. And that is actually the only time I put drains in kids for a thyroglossal. But I do not routinely place drains in patients after the surgery. And I don't routinely give antibiotics either. And then we close them up and then we get out.
As you're kind of describing everything, I also think back to residency where, you kind of think of the cyst as kind of this round cyst that you're removing. But really, it's more like this glob with like projections and, maybe other cysts like, grapes. And like, I think that pitfall of thinking of it as just this defined thing, like a dermoid, as opposed to kind of like this more amorphous structure that requires you to take that kind of extra cuff of tissue. That's kind of like one of the key parts of preventing your recurrence, would you say?
Yeah, I think it's coming to the realization that the cyst that you see is probably not the only part of the thyroglossal duct lesion, I guess. There's oftentimes additional ducts behind the cyst, additional cysts. Excise all that out, then the patient is at risk for recurrence because it's incomplete. But, I do tell families it's not a super exact science, right? Like every thyroglossal duct is different and you do your best to try to get out every single element that you see. But there's going to be times where maybe the child has a microscopic duct that was not filled with mucus at the time and you just don't see it. I'm not going to routinely do a pharyngotomy on everyone. And I'm not going to routinely take excess tissue if I don't have to. And we'd certainly do our best to get everything out. But I do assure families that if I do see any pockets of mucus or cystic lesions, they're going to come out and I won't leave them behind. And that's all I can tell the families when I do this. I keep them overnight. I think there are a lot of practices that do send patients home. Maybe it's just me, but like every time I look at how much I remove, I always feel a little uncomfortable sending them home. And so it just makes me feel a little better at least. But to be quite honest with you, in the last 100 some plus patients that we've done, we've only had one patient have a post-op day 1 complication, which was a hematoma that needed urgent surgical drainage. But in terms of like the usual stuff like PO and pain control, it tends to be very well tolerated. Oh, going back to the surgery, I forgot to mention. So the one thing in kids that I think I really kind of beat on the residents on this because it's very easy to get lost is that soft tissue in children is very pliable. So it's very easy when you're kind of pulling something or retracting something to pull something that you weren't expecting closer to you than you want. And so there have been a lot of occasions where people have gotten really close to cranial nerve 12 when they're doing the suprahyoid part of the dissection because you're kind of pulling down on that hyoid bone and that muscle. And it's very easy to retract that hypoglossal nerve where it kind of curves up into the tongue. It's very easy to pull that down with everything. And kids are really small. And so it's very easy to get into it. It's just something that you have to kind of keep in mind.
For the child that you ended up having to do the pharyngotomy, you've repaired it, you've closed intrinsic muscles, and maybe you've left a drain in, they stay overnight. What do you like to do now for PO? Do you do clears? Do you still do MPO, or do you just start them on a regular diet?
I do clears overnight, basically just take it easy. And then the following day, we'll advance them to like a soft. And if they tolerate soft, they can go home later in the evening. What I used to do was I would do sort of how we do our cancer patients, but on a much more compressed time scale, like MPO overnight, grape juice in the morning if they have a drain, just to make sure that there's nothing in the drain, and then, PO afterwards. I've not had a fistula or a leak yet, so perhaps that's probably too conservative an approach, so I've tried to slowly move away from that.
Do you do antibiotics for those kids, or do you still not do antibiotics unless you're worried that they're actually having anything coming out of the drain?
I will do 24 hours antibiotics, but there's probably not great evidence supporting that practice, to be quite honest with you. The patients do get they'll get a dose of perioperative antibiotics for this, so usually that should cover it, but because we were in the pharynx, it does make me feel a little better about doing at least 24 hours. We have not seen an uptick in infection rates though, so I even question whether that's necessary.
And thinking about just complications, we talked about pharyngotomy may be a complication if you don't recognize that you made one, right? We've all seen patients where there was an accidental pharyngotomy that went unnoticed. You talked about the hypoglossal nerve that's in the neighborhood and that can be damaged. You mentioned hematoma, seroma. What other complications do we need to be talking to our patients about?
What I tell families is that the most common complication of the surgery is recurrence or swelling, seroma or recurrence after the surgery. I think the numbers are kind of all over the place in terms of how frequently recurrence happens. I think the average is 5 to 10%. And I do tell parents, look, the reason I think this happens is not because the cyst came back. It's probably because I or whoever did the surgery didn't see a small pocket somewhere, and that pocket is starting to produce mucus, and now you've got swelling because of it. So I do warn families the most common complication is going to be recurrence. It happens up to 10% of cases. And what you oftentimes will see is swelling within the first 1 to 2 weeks after the surgery. And how I manage those, it really depends on the child. So if the child is not really bothered by it, meaning that they just have swelling, I'll leave it for now. I'll observe it because oftentimes it will actually resolve. It will kind of reabsorb. If it's bothering the child or it looks like it's getting infected, I will tap it in clinic. I will drain it with a needle. And I don't actually really numb these patients up. I just go through the incision site because that area is going to be insensate, so they're not going to feel anything. And usually what I draw out, actually, almost always, I get this mucoid kind of material, it just looks like mucus. And so I tell families, look, it looks like mucus. He may have something there that's producing that mucus I didn't see the first time, but we'll give it some time, see if it'll go away on its own. If it goes away and it never reappears, then we don't need to think about a reoperation. And I'd say the vast majority do go away on their own. I do counsel them that after it goes away, though, it doesn't mean that it's going to go away for good. So if it reappears again, please call me back so we can kind of figure it out. But until it shows up again, there's no reason to look for trouble, right?
For that initial post-op, meaning it's post-op week 1 and there's some swelling or maybe there's some drainage through the incision site, is that what's going to tip you off as the mucoid return or mucoid drainage? Because I would imagine that seroma or wound infection, could also be in your differential, or is it 90% of the time recurrence and a handful of times is it seroma or wound infection?
I'd say 95% of the time it's a mucoid seroma.
Okay.
And then of those, maybe a few will have an infection on top of it. And so, yeah, I wish when I tap it, it's just thin liquid, because then that'll make me feel a lot better. But 95% of the time it's not.
And when they settle, fizzle out, do you put those kids on antibiotics, or you've tapped it, or, hey, it's a little swollen, I don't think we need to tap anything, let's just watch you? Is there any benefit in a course of Augmentin or something at that time?
For me, it's based on clinical exam. So if it's tender, red, then I'll put them on antibiotics. But if it's just a bump and the kid's acting normally, I don't put them on antibiotics. I don't recommend draining those, because the other thing that tends to happen when you drain these is that they can recollect. So I always warn families, we're going to drain it now because it's going to make him feel better, but it may recollect, and it may recollect in a few days. If it's bothering him when it recollects, please bring him back, and we'll just keep tapping it until it goes away or it stops bothering him. And some kids will need 2 or 3 attempts to get it to go away. But I try to manage these outside the operating room if I can.
Yeah, because going back is just not as elegant once you've already been there, right?
Yeah. And, like I said, the incision site should be insensate. So, the kid may freak out, but in reality, they're probably not actually feeling the needle because you're going through an area where you've already kind of been. In terms of other complications, we've talked about the hypoglossal nerve. And going back to the pharyngotomy too, I actually don't see the pharyngotomy as a complication unless, like you said, it's unrecognized. I see it as part of the operation when it's necessary to remove it. Parents always ask about voicing, swallowing, breathing, and really should have no impact on any of those 3 things. And so I would say overall a very well tolerated surgery. The most kind of frustrating thing are the seromas and the recurrences that you sometimes will see.
And then how do you follow your patients? So let's say no issues post-op, maybe you've done a post-op visit, talked about the path. Do you survey them, and do you have a way in which you follow them?
If they don't have a seroma at the 3 to 4 week mark and they look great, I discharge them from clinic. If they've had a seroma, then it does concern me that they may have some thyroglossal duct cyst part or whatever that still remains in their neck that could cause a problem. So I'll see them back in maybe 6 months just to check in. But those visits tend to be really short and quick because most of the time the kids are doing really well. And then at that point, I just counsel them like, look, there may be something there. If it's not bothering them, don't worry about it. If it shows up, call us. We're going to have to go look for it. But until that causes a problem for them, don't stress. Just treat them like a normal child. And then we just kind of discharge them from clinic at that point.
For the child that maybe it's been a year and you see them back in clinic and now there is maybe some swelling there, what do you do next? How do you manage that? I know that's kind of that could be a part 2 podcast, but what's your management in terms of is that when you get your MRI, or do you start with an ultrasound at that point? And then, if you do have to go to the OR and your suspicion is high for recurrence, what are the nuances there?
Yeah, so in those kids, I'll start with an MRI. Like if there's clearly something there, I'll just get an MRI and just see. And I prefer MRI for these, right? Because MRI is really good at soft tissue differentiation and identifying fluid. You can see fluid really well. It'll be really bright on T2. So that's why I prefer, because these are fluid-filled cysts, fluid-filled tracts, so it'll show up real nicely on MRI. One of the reasons I do prefer the MRI for these is because if there is something in the base of tongue and I see it on the MRI, it lets me know that perhaps we just needed to do more of the foramen cecum, and I can kind of just go look for it. But that's like, a patient of mine. Like if it's one of my own patients, that's how I would approach it, because I know I've done the cyst and gone through the hyoid bone already. If it's coming from somebody from the community or a referral or a patient who, had a cyst years ago by someone else, I still get the MRI because it kind of helps me know like what's been done in the neck already. Also helps me identify if there's any disease in the base of tongue area. Unfortunately, on the MRI, it's really hard to see the hyoid bone, but I think it's just really helpful. I think it's good practice, especially if you're going back for revision surgery, to have some sort of cross-sectional imaging to help you plan. Surgically, though, I would almost say that the surgery is a little easier when you're talking about a recurrence, because at that point, you're not really looking for the hyoid bone anymore. And the ideal situation is the patient actually does have something that you can feel, and then you basically kind of follow it, core it out. You do want to leave a little bit of soft tissue around it because, we've kind of talked about this before, but these little projections that you worry about, you just want to make sure you get all of it. And then you just kind of follow it down to the foramen cecum. And if there's cyst or ducts there, you just keep going until you get it all out. I actually just recently did a kid who had a base of tongue recurrence, like literally in the vallecula. We had to chase it all the way down. And he was quite challenging because we saw it on the MRI, but he had no external defect. So like there was nothing for me to follow. He had come back with an infection a year later. And then the MRI showed that he had a 1 centimeter cystic mass basically in the vallecula. So I told the parents we could do it, but there's a chance I couldn't find it. And it was challenging trying to find it because you're just going through scar tissue and then suddenly there's like a sac there. And you're like kind of looking for a needle in a haystack.
Thank you so much for really kind of getting into the nitty-gritty. As we're rounding things out, is there anything else that you feel like we haven't touched on that is important?
I think the biggest takeaway that I tell the residents is that you always have to find your airway before you make your hyoid cut. I've done this operation hundreds of times. I still get that feeling, that feeling where you're like, before I cut, and I'll oftentimes double check to make sure that I actually feel that notch. Because I think a mistake that does happen, thankfully not very often, is that there is sort of a notch in the cricoid itself, right? Like the cricoid, sometimes you'll feel a notch, and people mistake that as the thyroid cartilage, and they kind of sweep up, and then they proceed to cut whatever is above that notch, and it turns out to be the thyroid cartilage. And that has happened.
That has happened. I was on call, actually, when a child that had that happen got transferred in.
And I think it happened again after you left.
Yeah.
And thankfully, it doesn't happen very often, and it has not happened at our institution, but it can happen, and people can make mistakes. And so the biggest takeaways for me for this surgery are really you have to find your thyroid notch and you have to be absolutely sure. And then you also have to remember that the hyoid bone is the only bone that you can get your finger under. And so if you can't get your finger under it, then you're probably not at the hyoid. And so you might want to take a step back and reevaluate where you are. Because I think that part of the operation is where you can really hurt someone if you're in the wrong spot. So that's my big takeaway, at least for the residents. That's why I told them.
Yeah, very well put. Chris Liu, dropping knowledge.
Thank you so much, Chris. No, I think that the final pearl is super important. It's not just for the residents. I mean, I practice the same thing. It's like I got to make sure. I remember Romaine Johnson taught me that same thing. You find that notch. You got to find the notch.
Well, one time I didn't really find the notch with Mitchell when I was a resident. And oh my God, the kid refused to talk afterwards. And I thought I was going to quit residency because I sort of got, cut through the thyroid cartilage, but Mitchell said I did. But I didn't find a notch. So I was never sure if I did or not.
Yeah.
That feeling is not a good feeling after an operation,
Totally.
So one of the lasting emotional traumas from that operation.
Yeah,
so
for sure. Well, thank you so much.
Thank you, Chris.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, direct message us at _BacktableENT on Instagram, LinkedIn, or Twitter. Backtable ENT is hosted by Gopi Shah
and Ashley Agan.
Our audio team is led by Kieran Gannon, with support from
Josh McWhirter,
Aaron Bowles,
Nick Shellcross,
Josh Spencer.
Design and digital marketing led by Brian Schmitz, with support from
Taylor Spurgeon Hess.
Social media and PR by Chi Ding.
Administrative support provided by Jamila Kennebrew.
Thanks again for listening and see you next week.